Yes, sir.
Okay. Now, the next is about the cystic lesions in the liver. Cystic lesions in the liver are mainly of four varieties: simple cysts, multiple cysts arising in settling polycystic liver disorder, or parasitic or hydatid cysts and cystic tumors. Among them, that simple tumors and the PCLD, they do not have much of a clinical significance. It's only that they are presented as asymptomatic conditions, and usually they will not have any harmful effects on the body unless there is a very huge swelling or multiple cystic lesions which can affect the or reduce the total liver tissue. The only these findings could be a palpable mass, or at times it could be only an accidental finding in the ultrasonography. When you do the ultrasonography, you may see cysts as such. So, in general, cysts do not require any specific management because they are otherwise harmful. Only when the size is bigger, and the general standards is if the size is bigger than 4 centimeter, then it needs to be monitored, like whether the size is increasing or not. Follow-up ultrasounds are performed to see whether they are increasing in size or not. And if these cysts are stable for about 2 to 3 years, do not increase in size, absolutely no need of follow-up, nothing to worry about them. But if the size is increasing and if it is going beyond 8 centimeters in diameter, because that size itself can produce the compression of the tubes or duct systems of the tissue, liver tissue, they may require the treatment, surgical treatment of exploration as such. Otherwise, they do not require any treatment. Very rarely, a simple cyst in the liver may get infected and may produce an abscess. Whereas polycystic liver disorder is presented with the multiple cysts, again, that too could not have any clinical presentation except in very late stages where there could be a chronic hepatic failure. And because the cysts are multiple, and usually polycystic liver disorder also is accompanied with the polycystic renal disorder. It's a genetic congenital pathology, and there again the protocol is the same. Like they, unless the size is quite big and unless there is a sign of hepatic failure, there is no need of intervention. And if there is a need for intervention, it would be like you will have to puncture all these cysts in large numbers, which again would be not really ideal, and most of the times in such conditions intervention can be harmful. But otherwise, if you leave it as such, it's not going to harm till very late stages. Only very rare conditions where there is extensive cyst as such may produce a hepatic failure as such. From the clinical point of view, the next important condition is the protozoal cyst, that's the hydatid cyst. Hydatid cyst as such, the of course, the choices in case of the polycystic kidney disorder are in the polycystic liver disorders, the general management would be if there is no symptom as such, there is no need of treatment. If there is a need for treatment, then the options of the treatment would be to reduce the natural growth. Somatostatin is one of the drug which is often used. Then to reduce the size of the cyst as such, either it could be aspiration or fenestration. Surgically, it could be just removed or opened and then resection could be done. Or if it is a very serious condition, a liver transplantation may be required. That is the general protocol. But majority of the patients do not require any treatment in case of the polycystic conditions. From the clinical point of view, the more important condition is the protozoal cyst there to the cystic echinococcus or echinococcus cyst as such, hydatid cyst. Now, comparatively, incidence of the hydatid cyst in coastal area is lesser, but in Malnad area, higher areas, the hydatid cyst is more common. Certain areas and hydatid cyst is produced due to echinococcus granulosus, a sort of tapeworm, and the life cycle of that echinococcus would be present in the intestines of animals, and where animals are considered dogs and the others, goats, etc., even sheep, they are considered as the primary hosts, and they will be presented in the muscles. They will be lodged in the muscles of these animals, and those who eat the flesh of these animals without proper cooking, the cysts, they may be entering into the body of the intestines, and then of the intestines of the human body, and they may produce the multiple cysts as such. So echinococcus gets into the muscles of the animals, and then from there it gets ingested by the human being, and when from the intestines these cysts may migrate to the liver, and they may produce the cystic lesions. These original eggs of these would be leading to the formation of the cyst. Of course, hydatid cysts can also present in other parts of the body, like the lungs or even in the brain. They may produce the cysts, or in the peritoneum they may produce cysts. Rarely a hydatid cyst may be formed in the bones too. But the most common site of the hydatid cyst formation is in the liver as such. So from the clinical point of view, hydatid cyst is an important issue for the liver pathology. Incidence of hydatid cyst pathology is more common in certain geographical areas like African countries. Compared to that, the incidence in India is comparatively lesser, but even in India, the maximum incidence would be in the northern India, in the eastern parts of northern India, Ganga ranges like Banaras, Bihar, etc. The incidence is quite high. In Karnataka, in Malnad area, it's somewhat common. In coastal area, it's very rare. So chances of seeing a case of hydatid cyst in Udupi is very low, whereas it could be seen elsewhere. But from the global point of view, echinococcosis or hydatid cyst is one of the rather major health issue, and the WHO has given a typical these key guidelines about the echinococcosis, and those WHO key facts are as such. I have copied it. That human echinococcus is parasitic disease caused by the tapeworms of genus Echinococcus, and the two most important forms in the human are cystic echinococcus hydatidosis and alveolar echinococcus. Alveolar is in the lungs. Humans are affected through the ingestion of parasitic eggs in contaminated food, water or soil, or after direct contact with the animal hosts also. Echinococcosis is often expensive and complicated treat, may require extensive surgery and or prolonged drug therapy. Prevention programs focus on deworming of the dogs, which are the definitive hosts. In the case of cystic echinococcus, preventive measures also include deworming the dogs or slaughterhouse hygiene and the public education. So, from the global point of view, prevention of echinococcosis has taken a rather high importance, and in those endemic areas, precautions are taken. And incidence of hydatid cyst is about more than 1 million people at any one time in the world. Now, hydatid cysts as such are typically having three layers, membrane-like layers. The outermost layer is what we call as a pseudocyst. The pseudocyst is it will be produced due to the compression of the liver tissues. The cyst actually starts growing within the tissue, and it starts growing in the tissue. It forms a layer called as germinal layer. From the germinal layer, you will have the new cyst formed, and the cyst would have multiple small daughter cysts and having fluid, a clear fluid, which is also having present there. And the next to the germinal cell layer, you will have that pseudocyst formation, the compact layer outside, as such. So, in a typical hydatid cyst, the identification of these would be seen, that typical three layers, the pseudocyst, then the true cyst layer, germinal layer within. These are the three layers seen, and they may present in any other organs of the body like bones, kidneys, spleen also. And alveolar is usually is presented as a tumor-like lesion, and it takes a long time. The incubation period is quite a long time in case of the alveolar pathology, and it may be presented as a small multiple cysts without this kind of a outer cyst formation, that outer layer. Comparatively, alveolar echinococcosis is very rare in India, whereas the majority of the hydatid cyst conditions which you may see in India are of the cystic forms, the hydatid cyst forms as such. Now, this ultrasound imaging is the most classical method of confirming the hydatid cyst. Clinically, the hydatid cyst doesn't produce any significant clinical symptoms till very late stages. One of the common clinical symptoms of the hydatid cyst is episodes of itching reactions produced due to the release of these worms into the body. And of course, in due course of time, it may present with the hepatic failure signs. Jaundice is seen only in very rare condition. Only in the late stages, jaundice could be seen. In general, in addition to these, the other clinical symptoms the patient may have would be reduced appetite, vague gastrointestinal tract symptoms like flatulence, and a palpable mass are the usual clinical signs of a hydatid cyst. Confirmation of the hydatid cyst is done by ultrasound, and in the ultrasound usually you get the grading, and the grading would be based upon the appearance of these cyst layers. If the outer cyst layers are calcified and the content is somewhat is heterogeneous, it's categorized as inactive. So in ultrasound, and it's graded as C4 or C5, which is suggestive of inactive. Then if there are multiple compartment-like appearances, the membranes as such, and then brooding membrane is very clearly seen, that's graded as C3, C4, and it's considered as a transitional. Active lesions are categorized as CE1 and CE2, where you will have the cyst as such and the membranes are just being formed with these categorizations. That's about how the cysts are classified in the ultrasonography, and this gives an idea like how to approach to the management. Now, the same type 1, what I have told is the same, the classification. CE1 is unilocular cyst, and C3 is detached membrane, where membrane is becoming like, and C5 is cyst with a bulk calcification, which suggests of a inactive pathology. So the activity, disease activity is measured by the ultrasonography, and this is the standard protocol to make out the identification. Further identification of the cyst will be by the serological test. Serological test hydatid cyst is now available, where by injecting that the reagent, this antigen, you can see the reactions and then make out whether the patient has a hydatid pathology or not. So confirmation of the diagnosis of hydatid cyst is by serological tests as well as the ultrasonography, which gives you a clear idea. Clinical history is quite vague, as I told you, but whenever there is a symptom of that itching and rashes along with the mass in the liver, you need to confirm it could be whether it is a cyst or not. Now, once the cyst is seen, the treatment protocol is a large number of the cysts, particularly in the early stages, as such, C1 to C2 as such, where in the initial stages of the formation, where the disease is, this activity is still seen, the better treatment is a drug treatment. That's mebendazole, albendazole or mebendazole is the drug treatment, and this gives excellent results. Antihelminthic treatment, which may have to be repeated once in 6 months as such, or or it may be treatment for about 6 months as such duration, depending upon the condition. And the dosage of albendazole for adult is 400 mg twice a day for 6 months, whereas pediatric dose 10 to 15 mg per kilogram up to 6 months is the usual standard treatment, and majority of the conditions they can be treated medical, and surgical treatment may not be necessary if the treatment is started in the early stages as such. And the general rule is, again, if the size is more than 5 centimeters, then you think of maybe albendazole with maybe aspiration also. But aspiration of hydatid cyst carries certain risks. The risk is if the fluid spills into the peritoneum during the aspiration, there is always a possibility of daughter cyst formed in the peritoneum. And hence, if at all there is a need for intervention, the rule is before you do the intervention, you have to inject formaldehyde into the cyst, and then the cyst has to be handled, either aspiration or maybe penetration or drainage, or maybe complete removal, excision also are the options. So you may have either a total cystectomy where the whole cyst could be removed, or subtotal, or just the liver lobe itself could be removed as such, depending upon the condition and the choices. But important is handling of this would be always better, always done with the after injection of formaldehyde into the cyst, and then wait for half an hour, so that all that active components of the echinococcus would be dead, and then only you have to handle it. That's one of the important precautions. And of course, if there is a calcification which has reached the stage of C5, then better not to intervene, wait and watch would be the other policy, because it's not going to harm as such. So that's about one of the conditions which may have some significance from the clinical point of view. Next of the condition is about the tumors of the liver. Now, among the tumors of the liver, the benign tumors are hemangiomas, and then cystic tumors. Liver cysts are cystic tumors, adenomas or focal nodules. These are the types of the tumors which usually would not have any other clinical presentation. Either they may be identified accidentally during ultrasonography, or they may be presenting with a palpable mass. Hemangiomas may present with a soft mass as such. Now, in all the benign liver tumors, chances of a liver function being affected or producing any other clinical signs of the liver failure are very low. It may be depending upon the location. A tumor mass which is closer to the porta hepatis may produce a compression upon the biliary system and may produce the biliary obstruction, whereas a similar mass or even a bigger mass elsewhere may not produce any symptoms as such. Hence, whether they require a interventional treatment or not would be depending upon the location as well as the progression of the lesion. But from the clinical point of view, whenever you see a palpable mass or a suspected mass in the liver, it has to be confirmed, like whether it is a benign or malignant, and to confirm that you may require either the imaging, this CT imaging can give you a better idea of the differentiation between a hemangioma and a adenoma or the asset. And if it is a confirmed hemangioma, biopsy is generally not necessary. But if there is a suspicion of adenoma, a histopathological assessment to rule out a malignant lesion or changes in the malignancy is necessary. Otherwise, they do not require any active treatment. Virtually, there is no question of any medical treatment too, as long as they produce a compression signs. If they produce the compression signs at the porta hepatis, then surgical treatment is the only option there as such. Now, the next important condition is hepatocellular carcinoma. Hepatocellular carcinoma is one of the maybe the new disease burden. Like the number of cases are increasing rapidly throughout the globe, and this is one of the major concern of the area. And one of the disease which would have comparatively poor prognosis, malignancy of the liver cells is one. As far as the causes of hepatocellular carcinoma are concerned, cirrhosis is considered to be the most important precancerous condition. A large number of cirrhosis patients would be converted into hepatocellular carcinoma in due course of time. And that's what we have discussed in the context of cirrhosis. It may take around 2 to 30 years. So it's unpredictable. Like when the patient of cirrhosis goes into hepatocellular carcinoma is unpredictable. It may take about 2 to 30 years as such. If there are still triggering factors for the hepatocellular carcinoma or this cirrhosis, it may convert into hepatocellular carcinoma early. And hence, any patient of cirrhosis has to be monitored for the possibility of hepatocellular carcinoma whenever there is any specific clinical event. Then hepatitis or hemochromatosis or so on, they also, even without cirrhotic changes, they may produce the hepatocellular carcinoma. And the relation of hepatocellular carcinoma with the environment and carcinogens are well known as such, and genetic pathology also is one of the factors which can produce a hepatocellular carcinoma. The major risk factors of hepatocellular carcinoma, other than that of the cirrhosis, are cirrhosis, hepatitis, and The obesity and diabetes, alcohol abuse, obesity and diabetes also is known to be a well-known cause for the hepatocellular carcinoma. And anabolic steroids, consumption of anabolic steroids, now it has been established, like persons who tend to take anabolic steroids to have a proper build-up of the body, or which is also used in sports, like as it's one of the banned drugs in the sports. But those who use that, or many times these anabolic steroids also are given in gyms to have that shape of the body, which are also considered as these nourishing food substances, but they are not really nourishing as such. But that's a possibility of resulting in hepatocellular carcinoma, and that relationship is now well established. Anabolic steroids consumption and hepatocellular carcinoma, their relationship has been now well established. Diseases like hemochromatosis, where there is a deposition of the iron in the liver, can also result in hepatocellular carcinoma. Hemochromatosis can occur due to hemolytic pathology or unnecessary consumption of the iron too. Those who tend to take iron capsules unnecessarily, the iron supplements unnecessarily, in excess, more than the standard dosages, they also have a risk of hepatocellular carcinoma. Then aflatoxins. Aflatoxins are fungal substances present in the food or particularly grains and foods where the toxic substance which is present in the form of a fungal mold would contain lots of aflatoxins, and these aflatoxins also are now known to be one of the triggering factors for the hepatocellular carcinoma. Clinical presentation of the hepatocellular carcinoma is mainly jaundice and cachexia. The most common clinical early symptom is the cachexia. Weight loss is the most common and early symptom. Patients who tend to present with the weight loss and reduced appetite as such. Then the other symptoms could be a gradual, the jaundice is the other symptom which is quite important. Jaundice with the pruritus, itching, that's due to obstructive pathologies as such, and jaundice with the extensive pruritus is also very characteristic. Splenomegaly and GIT bleeding and abdominal gut being increased due to the portal vein occlusion, and of course the signs of ascites also can be presented. Patient may have hepatic encephalopathy. It may result in acute hepatic failure too. That too can be the clinical presentation of hepatocellular carcinoma. And pain in the area is very rare, uncommon. So in a case of hepatocellular carcinoma, pain is very uncommon. And a diagnosis of hepatocellular carcinoma is better done by MRI study than the USG. USG gives the idea that the location of the tumor with the heterogeneous content can be made out of the USG, but a MRI can give you a better image of a clear-cut border and then having necrotic tissue as well as the abnormal tissue, which is almost confirmatory. Of course, it's not that it can replace the histopathological evidences, but MRI is now considered to be very dependable means of making the diagnosis of hepatocellular carcinoma. Another tumor marker which is very commonly used as to identify the hepatocellular carcinoma is alpha-fetoprotein. Alpha-fetoprotein is a specific protein present in the embryonic life, and in the newborn it's present in very high quantities, and by the time of around 36 to 40 weeks it comes down, and in men, adult men and these females, non-pregnant women, the quantity ranges 0 to 40 nanograms per ml. If the level is raised above, then it may be suggestive of the hepatocellular carcinoma. The general guideline about that level of alpha-fetoprotein and the possibility of hepatocellular carcinoma, particularly alpha-fetoprotein, is now used as a screening for high-risk patients, those who have a hepatocellular carcinoma history in the family. They are screened for hepatocellular carcinoma, and these levels are important. If the level is above 400 and up to like 400 to 500 so on, there is a possibility of a hepatocellular carcinoma with a quite huge mass and diffusely growing variety, and which may be difficult to detect on imaging. See, diffusely growing hepatocellular carcinoma may not be easily detected in ultrasonography. MRI, of course, is more dependable, as I told you earlier. And in such cases, alpha-fetoprotein can be one of the more dependable means of guessing about the possibility of hepatocellular carcinoma. In certain of the patients with active liver disorders like viral infections, also alpha-fetoprotein may be increased, and there it may be somewhat ambiguous. If the level is between normal to less than 400, then there is a possibility that the patient may have a lesion of hepatocellular carcinoma, or maybe some space occupying lesions as such, and there you have to suspect. Particularly, a high level can be possible in patients who have undergone resection of the liver. Patients who have undergone resection of the liver, it's one of the possibility. And quite important is a normal level of alpha-fetoprotein doesn't rule out, doesn't exclude hepatocellular carcinoma if there are clinical evidences. So, diagnosis of hepatocellular carcinoma now is based upon either imaging studies, tumor markers, or ultimately the biopsy. Overall prognosis of hepatocellular carcinoma is extremely poor, even with the newer techniques of the treatment. And 5-year survival rate at present, the latest, best of survival period, 5-year survival period is around 18.4% even with the newer techniques. One of the newer techniques which has come up now is chemoembolization, and new agents, new variety of agents like trozins, newer derivatives of immunological modifying substances. They are used now as the treatment, and these also, the newer treatment also have produced poor results. And there is a general protocol, of course, general protocol of treating cases of hepatocellular carcinoma is, if it is in the early stage without secondaries, resection is more dependable, which is considered as a curative management. Whereas if this resection is not possible and still it's comparatively in the early stages of stage A to C, then liver transplantation could be tried as such. But if it has crossed that limit, then it's only the disease modifying drugs like chemoembolization or the newer agents are used. And of course, if it has reached the terminal stage, the D stage, then only symptomatic treatment. There is no question of a curative treatment and such. And as such, that's the standard protocol of dealing with hepatocellular carcinoma in the present day situation. Then the next variety of the carcinoma tumors of the liver is the cholangiocarcinoma. Cholangiocarcinoma is a carcinoma or tumor developing in the biliary system, in the biliary duct. Depending upon the pattern, they are classified as either a mass-forming lesions, which are comparatively less common, and or maybe periductal infiltration, some the less common, or intraductal. Now, among them, the differences are, in a case of mass-forming tumors, it may be presented as a mass, and hence it can be easily diagnosed with the ultrasonography. Whereas intraductal and periductal, the lesions would not be identified by the ultrasonography easily, and more important is they do not present with a mass. The size of the liver also may not be increased, so you may not have a palpable finding there, or palpable findings can be easily missed in such cases, and that's why cholangiocarcinoma is important. So cholangiocarcinoma is now graded based upon the distribution, like whether it is in the present mild, these final ducts like bile ductules or segmental ducts is categorized as CCA. Then if it has involved the common hepatic duct, that's at this area, then it's called as a PCCA. And then if it has involved the common bile duct at a lower level, that's called that's categorized as a DCCA. And the majority of the patients whom we see would be of the common hepatic duct involvement. These hepatic ducts are involved as such, where only one duct, left or the right hepatic duct is involved. That's the more common variety of the cholangiocarcinoma which we see. The clinical presentation of cholangiocarcinoma are mainly jaundice, the main unexplained painless progression of the jaundice, and relatively fast growing jaundice. Characteristically, jaundice presenting without the pain. Now, when the jaundice presents with the pain and fever, you suspect hepatitis. A jaundice presenting without pain and fever, you suspect tumor pathology. That's a general rule. And of course, because it's an obstructive pathology, patient would have clay-colored stools as well as the urine, the bilirubinuria. The urine also will be dark color. pruritus, itching and weight loss, abdominal pain are the other clinical symptoms of cholangiocarcinoma. Treatment and survival period of the cholangiocarcinoma is depending upon the type of the grade of the cholangiocarcinoma. The survival period is around 3000 days maximum, and this is survival period as such. With the treatment protocol, there are many alternative choices of the treatment. The survival period maximum would be around 14 to 15 months. Even after surgery, the survival period is lesser. So outcome of cholangiocarcinoma is quite poor. I will not go into the details of how the treatment is and so on. But both hepatocellular carcinoma and cholangiocarcinoma have a poor prognosis even with the advance technology. And with this, we will come to the end of this chapter on the liver disorders. But before concluding these liver diseases, as we have already referred to, though Ayurveda literature has very little literature about the liver structure and the functions, among usually in the society you have a notion that for all liver disorders, Ayurvedic treatment is the standard treatment. Now, the very common Ayurvedic drugs which are mentioned in the text and which are now rather practiced, used in the practice as hepatoprotective drug and often referred to with maybe certain basic researches also. There are many drugs which are used as the hepatoprotective. I am just suggesting about the most commonly used hepatoprotective drugs, and this is from reference from Privarta Sharma Dravyaguna textbook, and with certain of the review articles where many studies are done, many experimental studies are done on these drugs, and based upon that total summary of all those activities or drug research is done, as well as from the textual references, these 10 drugs are selected by Privarta Sharma, who wrote that Dravyaguna textbook, as somewhat dependable hepatoprotective. So this list is directly from the Privarta Sharma textbook of Dravyaguna. So I will not add anything from my own, but majority of those drugs which are now used as a hepatoprotective drugs are sold as hepatoprotective drugs in the market and Ayurvedic brands. They would have either many of these or maybe all of these contents in as such. Now, from the global issue, globally also, throughout, though it's not only in India about Ayurvedic, non-Ayurvedic drugs also are now studied throughout the globe for treatment of hepatic pathology. Herbal drugs are tried, and this again from a review article where herbal drugs from all over the globe, which are tried and which are now studied for their contents. Like these are about those. Again, I will not go into all the details, and some of them are Ayurvedic herbal drugs also. But globally, you will have many more herbal drugs. Ultimately, the point is, in the liver pathology, there is our molecular medicine has almost reached to a dead end, and the major research now is about the herbal drugs. And throughout the globe, the study of herbal drugs are being done, and Ayurveda is another resource as such. So there is a need to have maybe a broader study and maybe more focused study about these issues, and that is one of the areas where we can develop. With this, we will conclude the liver disorders. The next part would be about the gallbladder pathology and the biliary system. We will start with that in the next session. So we will conclude today. Liver disorders completed. If there are any questions, I will try to answer those questions. Then we will wind up today. Bit early, no problem. Sir, are there any questions? No. Right. There are no questions as such. So let me conclude. Thank you.